Good morning, everyone. My name is Prasant Mahapatra. I'm the Vice Chancellor for Research. Again, it must be Friday, 10:30 a.m. And we have been using this time to discuss about current issues related to team science. As many of you would know, this series started during the COVID time, and slowly it has morphed into exploring new opportunities in research as we march through, advancing the team science. So Alison Brashear, the former dean from School of Medicine, and I collaborated on initiating this effort. As you would know, Alison has moved to a different university, and we are fortunate to have Kim Barrett play the partner in the crime with me going forward in these efforts. And today my role is to introduce Kim Barrett, and the theme of today's presentation would be on the post-COVID syndrome and what happens in the long run in terms of the COVID. So
the other positions that you're looking for, and then a reclassification that you're submitting, and then
what happened? Okay, please mute your microphones if you are not speaking. So Dr. Mark Abdelovic will be giving the presentation. I'll have Kim introduce Dr. Abdelovic, and Angela will follow up managing the question and answer sessions. So let me have this distinct honor of introducing Professor Kim Barrett, who I know from my previous role as dean. Kim was a distinguished professor of medicine at UC San Diego and the director of the Division of Graduate Education at National Science Foundation, and was appointed as Vice Dean of Research at the UC Davis School of Medicine, effective the 1st of November. We are really delighted to have Kim with us. And in this role, Kim will be charged in creating an innovative vision and future for research at School of Medicine. And as we all know, that emphasizes the collaborative effort on transformational research related to health. There will be many responsibilities and key initiatives that we'll hear from Kim as we move forward, and once she gets a handle on stabilizing on her new role. Dr. Barrett is an internationally recognized scholar in gastrointestinal physiology and has published extensively and received numerous awards for her academic contributions, as well as her teaching, administrative skills, and mentoring. These includes the 2021 Distinguished Achievement Award for Basic Science from the American Gastroenterological Association. Again, I have a lot more things to talk about Kim, but I'll hold it for some other day, and maybe in one of our future team science meeting, we will have Kim as the main speaker to learn more about her work. With that, let me hand it over to Kim, and Kim can introduce our speaker for today.
Thank you so much, Prasant, and thank you for the role that you played in bringing me here. I'm extremely excited to be here. It is now essentially a month since I arrived, and in the speedy way that we have in the University of California, I do finally have a UC Davis email. I have a badge, and I'm moving into a house in Sacramento tomorrow. So I'm definitely getting my feet on the ground. I'm looking forward to meeting people. It has been drinking from the proverbial fire hose for the last four some weeks, and it doesn't seem like it's going to slow up anytime soon. But I was so enthusiastic about being selected for this position because of the opportunities for team science and collaborative interactions, not only within health sciences, but of course with our partners across the Davis campus. And there are so many unique resources on this campus that we can bring to bear to address questions of human health and well-being. and also in the sort of One Health setting with our wonderful veterinary colleagues as well. So I'm not going to say anything further right now about my new role as Vice Dean for Research, but we will turn to the more important business for today to hear from our speaker. So as you heard, our speaker today is Dr. Mark Avdalovic, who is Professor and Vice Chair of the Department of Internal Medicine and a member of the Pulmonary Critical Care and Sleep Division. And I actually had a joint appointment in the pulmonary division back at UC San Diego. So I very great to see a colleague from those disciplines. It has been said that the core of high-level specialty care is effective communication with patients, their families, and referring physicians. Dr. Avdalovic is an effective teacher and listener for his patients and colleagues. He has extensive experience in pulmonary and critical care and telemedicine, focusing on interstitial lung disease, asthma, COPD, and pulmonary arterial hypertension. His research is largely centered on therapeutic interventions and cohort development in pulmonary vascular disease, and he heads the UC Davis Pulmonary Hypertension Center. In the fall of 2020, he started to organize a post-COVID clinic at UC Davis Health, and he also participated with Dr. Hatsku in submission of the UC Davis PASC post-acute sequelae of COVID-19 grant that was dubbed Do More, defining organ-specific involvement post-COVID-19 recovery, that was submitted to the NIH. And together with Dr. Christian Sandrock, he developed the clinical protocol for PASC evaluation and is the clinical lead of the post-COVID clinic, now dubbed the PASC Research and Care Clinic. The methods specific to this clinic incorporate innovative practice tools to maximize cohort recruitment, which I'm sure we're going to hear about. He received his MD degree from Medical College of Wisconsin, and he was a resident and fellow here at UC Davis Health. He's board certified in internal medicine, critical care medicine, and pulmonary disease, and he's a fellow of the American College of Physicians. He will talk to us today about post-COVID syndrome and his experience during the first 12 months of his new clinic. And I'm very excited to hear what you have to share with us, Dr. Avdalovic. Please go ahead with your presentation.
Thank you, Dr. Barrett, and thank you to the organizers for inviting me today. Would certainly have been a great pleasure to see everybody in person, and just sincerely, I hope that we get back to those times sometime in the near future. Today, I'm going to tell you a little bit about what we've learned after we started our post-acute COVID syndrome clinic. So largely today's discussion will be descriptive, but I hope that it lends some sense of the complexity of these patients and the opportunities that we have to learn more from them. I have no disclosures that are related to this topic. The outline today is I'm going to go over some basic definitions in epidemiology. This is quite important because the World Health Organization has actually changed the diagnosis description of the post-acute COVID syndrome somewhat recently. And that certainly will affect how we develop cohorts moving forward. And then I will go over some of the descriptions of the early days of our UC Davis post-acute COVID clinic and where we are today and opportunities for the future. So getting started with some basic definitions in epidemiology, the actual term post-COVID syndrome is kind of a grab bag for a wide range of both physical and mental health consequences experienced by certain patients. Initially, it was 4 or more weeks after a SARS-CoV-2 infection, but more recently, the World Health Organization has extended that to the persistence of symptoms that are greater than 3 months out from your original acute COVID infection. This can include patients who are both hospitalized and those who are not. And in fact, I'll try and demonstrate today that sometimes the symptom patterns and the cohorts that are related to those who survived a hospitalization versus those who were never hospitalized are somewhat different and unique. We were fortunate enough that although I would say coding and how we register notes clinically usually is a very slow moving process. With regards to the post-COVID syndrome, a unique code was created fairly early on, which allowed us to then identify these patients in a way that otherwise would have been very difficult. So the original code was B94.8, and that has recently been changed to U09.9. Oftentimes, this syndrome is referred to as long haulers. I'm not a huge fan of non-formal descriptions of what potentially are unique clinical syndromes. But unfortunately, in the lay press, this is how these patients are now categorized and identified. It is interesting when we look back in history that there were at least 2 other coronavirus-associated infections that also had some long-term symptoms that were present long after their acute infections had resolved. So we did see this with SARS 2003 and the MERS 2012 mini epidemics. Moving on, our theme here for basic definitions. This is a figure that I borrowed from a recent publication in Nature Medicine, which I highly recommend, which is a very nice review, a very basic review of the post-COVID syndrome. But it really illustrates in a timeline perspective of what we're dealing with from a potentially biological basis. When one is first exposed to SARS-CoV-2 in the first 5 to 12 days of exposure, it may be difficult to initially identify your infection using PCR. But within the first week or so after you've been exposed, there is the potential, if one had samples from your lower respiratory tract, which is shown here in purple, or the traditional nasopharyngeal swab that many of us are now extremely familiar with, that detection is complete. Within those first 2 weeks, the virus is actually more difficult to obtain from the lower respiratory tract as the infection goes on, but it can be continued to be detected from the nasopharyngeal surface for actually several weeks after. We actually have some patients who have continued to test positive months after their original diagnosis, which does present a bit of a conundrum, as many of you have maybe heard about folks in the lay press who, quote unquote, are reinfected with COVID 1 month after recently having COVID. And the reality is that for many of those patients, that's actually probably not true. It's just that the PCR detection persists in some patients for a very long time. The effect, what does that mean if one ends up testing positive from their nasopharyngeal surfaces long-term with respect to symptoms that they may have long-term? That process is a little bit less understood. As the virus detection becomes more and more difficult, it's really in that post 1 month to then 3 months and 6 months that we begin to see patients who seem to have a persistence of a collection of symptoms. It can be somewhat nonspecific, and we'll talk about this in a little bit more detail, such as fatigue or a general decline in quality of life, to very specific symptoms such as a cough, or palpitations, hypertension. Some patients have late onset venous thromboembolism, and the list of symptoms, frankly, can go on and on. I want you to start to think about how we think about these patients categorically. Those who've survived COVID as the acute infection, we first begin to categorize them in a category of, were they hospitalized? And if they were hospitalized, did they end up being in the ICU? And if they were in the ICU, how were they supported in the ICU? That is, did they end up on a ventilator, or were they simply supported through what's called high flow oxygen? Versus those who were hospitalized but never made it to the ICU, stayed on a typical medical surgical floor. These patients we look at slightly differently than those who were never hospitalized. And we'll go through some of the reasons why we now know that there's a separation between these two groups. Not a clear, distinct separation, but a somewhat of a separation. So I'm going to introduce a couple of studies that came out this year, but actually, particularly the first one points out one of the difficulties in this work is that with the World Health Organization changing the definition of what is truly post-COVID syndrome, some of what is described in these research studies is now not as valid within that timeline. But one of my favorite studies in looking at hospitalized patients is the so-called Michigan cohort of COVID patients. They looked at 1,250 patients from 38 separate hospitals that they followed 60 days post-discharge from the hospital. When those patients were contacted and evaluated in terms of what happened to them, close to 7% had passed away. About 15% of those actually required readmission for some of their specific organ symptoms. 32% reported that they still had symptoms at 60 days post-discharge. And that included about 19% that actually had new symptoms or worsening symptoms than what they remember when they were hospitalized. By far the most common symptom in these patients is feeling short of breath or dyspnea, and others included cough and then the persistent loss of taste or smell. Similarly, there was an Italian study that looked at a much smaller cohort of patients. Again, these are patients who were hospitalized, discharged, and then followed up at 60 days. As many of you remember, Italy was the second geographical location of the COVID pandemic, just prior to cases being seen here in the United States. In those patients that were followed in the Italian study, about 53% reported persistent fatigue, again, shortness of breath, high on the list, joint pain, chest pain, were all some of the most common symptoms. At least 55% continue to experience 3 or more symptoms, and this will become key a little bit later on. And a very significant percentage felt that they had a decline in their quality of life. Well, what about the non-hospitalized patient? Actually, I think some of the best data comes from our own University of California. This is the University of California COVID Research Dataset, or so-called UC CORDS. This is a chart review that looked at 1,407 records. They evaluated and looked for early symptoms versus late symptoms. 27% of those non-hospitalized with a documented COVID infection at 60 days plus had persistent symptoms. So close to a third of patients who had some version of a COVID infection, were not hospitalized, continued to have some degree of symptoms 2 months after their initial infection. The risk factor for this pattern seemed to favor female over male and those aged 50 plus. One of the most interesting things that came out of this study, and I think it's very appropriate to what we've seen in our own post-COVID clinic, is that patients, particularly in this non-hospitalized group, present in clusters. There are those who have more of a, we'll call it a respiratory cluster, where it's chest pain and cough, where they have irritation with heavy breathing, or if there's a change in temperature, it seems to trigger their symptoms. There's a separate sort of cohort that is more short of breath than they are really coughing. There's another cohort that has an unusual tachycardia. I won't speak to some of the details, but this is a very unique thing that we do see with the post-COVID patients. They have these bizarre episodes where their heart rates just jump up to an abnormal rate. It's typically sinus. It does not seem to be physiologically triggered, and it spontaneously will sometimes go away. That's not to say that everybody has it, but those that have this tachycardia, it's interesting enough, they also seem to cluster toward psychiatric symptoms such as anxiety. There's a separate cohort that has more of a gastrointestinal manifestations of their persistent symptoms, including abdominal pain and nausea. And then another cluster that seems more rheumatologic in terms of joint pains and muscle aches. Arizona took a somewhat similar approach. This is called the cohort, which prospectively, slightly different than the UC University of California study, in that they prospectively followed patients rather than retrospectively reviewing charts. They looked at 303 non-hospitalized patients. They again followed them for around 60 days. And at 30 days, those patients had 70% had at least one symptom. After 60 days, a smaller cohort that was followed at that point had 77 with at least one symptom. The common symptoms included fatigue, shortness of breath, what is now commonly termed brain fog, which you're going to hear me use this term, but basically what this means is that the patient feels that they're not as alert and their ability to calculate and concentrate is not what it used to be. And a significant percentage reported stress and anxiety. Again, interestingly enough, another study that pointed out more of a female prevalence within these post-COVID patients, non-Hispanic white, which I'm going to bring this up as I'm not sure this is actually reflecting reality, but a high percentage of non-Hispanic white patients, and on average they were around 44 years old, so somewhat similar to the other cohorts that were described. So what we now know from some of the other published literature that's out there is that if you're looking at patients who fall under the umbrella of post-acute COVID syndrome, meaning that they've had COVID and now have persistent symptoms at some defined time point later, if you look at those who are hospitalized and went to the ICU, the likelihood that you have some symptoms 2 months or later is 60 to 80% of the time. So it's almost a virtual certainty that if you ended up on a ventilator and you survived, that you will have some persistent symptoms. This, of course, is not that novel. We've seen this before with other viral infections, other respiratory infections. When somebody survives a very significant ICU stay, they often have long-term symptoms. If you went to the floor, that likelihood of having long-term symptoms goes down. If you're not hospitalized, it's about a third. Interestingly enough, depending on what your presentation was, your distribution of symptoms may include all of the ones that are listed below, as well as many others. So let me turn my attention to our own clinic. So that was a little bit of background in epidemiology. I'll go through some of the details of our clinic. So we created this clinic in November of 2020. To be honest, this was spurred on by something that we were organically seeing within our own patients who either had COVID and were coming to see us in clinic, survived COVID after a hospitalization, and to be quite frank, in many of our colleagues, as you are all aware, in the very early days of the pandemic, several healthcare workers were affected. And we saw in our own colleagues that there was a persistent of a bizarre set of symptoms. As a result, we got together and we said there might be some value in giving these patients a central location to be evaluated, to be seen, and to be linked up with an appropriate specialist who is interested in their organ-specific symptoms. In other words, the improved access would improve their care. Our original specialty partners included cardiology, rheumatology, infectious disease, psychiatry, neurology, ear, nose, and throat, and GI medicine. We are now part of the UC Office of the President Post-COVID Consortium, which is a group of other UC post-COVID clinics that meets more or less on a monthly basis, and we review our experiences. Our ultimate goal is to develop a UC-based database of these patients so that we can potentially understand their symptom patterns and understand their biology better. So I'm going to present some data here, and what we did is we took advantage of the new codes that were made available to us in January of 2021, and we highly encouraged clinicians throughout the health system to use this code when they felt that they were seeing a patient for what was truly a post-COVID symptomatology. So if we look at just that group of patients who were seen anywhere in the health system, approximately 640 unique patients have walked through the doors of UC Davis Health with a diagnosis of post-COVID at the encounter when they were seen at UC Davis Health. I'm being very specific because that is indeed what this data is showing you. It's showing you these 640 patients, and I'm giving you the top clinical locations that they were seen. Of course, there's many others, and that's what's presented in the purple bar here, multiple other clinic locations, but the top clinics was our respiratory J Street Pulmonary Clinic, which serves as the entry point hub for the post-COVID patients. These patients were also seen in our neurology department. Some of our primary care clinics were very high in terms of seeing these patients, including Elk Grove, Roseville. Our ENT group has seen these patients. This is basically my clinic here in Folsom, which is where I am today. I have a clinic in Folsom on Fridays, and some of the post-COVID patients are seen here by me. And then, as I mentioned, a whole host of other locations. How did we design the clinic? And when I say designing the clinic, these are the patients that we actually centrally want to start their care through our clinic here in the pulmonary division. What we did is we set up a consortium of partners that I already described, from rheumatology, cardiology, pulmonary, and several other specialties. These partners are clinicians and clinician groups that are willing to see these patients when there's a symptom-specific, organ-specific syndrome that is specific to their specialty. The design of the clinic is that the patients are centrally seen. There's an intake process where we capture their history of present illness, their previous disease history, physical exam if they're seen in person, but in fact, many of our patients as an initial touch point are seen virtually to help with their access. We have a unique order set that is specific to the post-COVID syndrome. So it allows us to retrospectively look back and see what are the orders that are used by the various number of clinicians. And this includes pulmonary function testing, echocardiogram, EKG, chest x-ray, and several other things. I'm not going to go through that entire list. Not every single lab is ordered for every patient. It is specific to how they're presenting and what their symptoms are. We also have a social worker that now connects with the patient actually prior to their initial intake exam to identify areas where they may need help with, whether it's hooking them up with durable medical equipment needs, insurance issues, anything that sort of helps from a quality of life perspective improve things. And that touch point is done very early on. I want to highlight some of my clinical partners. Within cardiology, Dr. Javier Lopez has taken the lead on seeing these patients and has done a really fantastic job. I can't say enough. Dr. Leonards is part of my group that meets with the UC Office of the President, and he has a group of neurologists that have a very keen interest in these patients. Dr. Ridgway from rheumatology, Toby Steele at ear, nose, and throat, and these other specialties. Multiple clinicians are part of their groups, and they are part of our clinical partners. So let's look at the patients that actually start with that initial intake through the respiratory J Street Pulmonary Clinic. So this is sort of the starting point patients. There's been 394 unique patients in the last year. Again, very similarly to some of the studies that we've reported on earlier in this talk. Almost a 2-to-1 female to male. This is interesting because if you look at the data of inpatients, patients who are in the hospital with COVID, it's the opposite. It's 2-to-1 male to female. And so it's interesting that these symptoms tend to linger within our female cohorts. The distribution of age, again, very similar to what's been described in other studies. So this is reassuring that we are seeing a somewhat similar pattern to what's been reported by other groups. The largest group represented is between the ages of 27 to 54 years. I point this out, this is a distribution of patients by race. How are we getting this information? The patient has to designate themselves from a race and or ethnicity standpoint. Many patients actually choose not to designate. So that's why you will see none of the above is the most frequent answer. But in those who did answer, white is the most common. And I will tell you that I'm not sure this is reality. And what I mean by that is, I think our clinic and the way it's designed is not entirely open so that those who are in an underserved or in an access situation that is not ideal, I don't think they have the ability to be seen by us. And so I think the data here doesn't reflect a reality that those who are Caucasian are more likely to have post-COVID. I think it really reflects, again, this is my personal opinion, that it reflects an issue of access to the clinical care. And it is something that we want to work on that I'm going to highlight at the end of my talk. Similarly, again, if you look at ethnicity, again, non-Hispanic white is the highest represented group. So what is it that we order off of our unique order set? Well, without question, the most common thing that we're ordering is lung function testing. Now, if I pull the lens back and I look at patients who happen to have been seen in other locations within the health system and not through the post-COVID clinic, then this pattern does change a little bit. So there is a little bit of bias probably because the patients are starting off in a pulmonary clinic. So pulmonary function testing is the most common test. But we also look for evidence of ongoing whole body inflammation with C-reactive protein, autoimmune disease. We actually sometimes have to retest them for COVID because we're curious whether or not they're having persistent symptoms consistent with infection. Many of the patients have some concern over ongoing clotting issues. So a test called the D-dimer is a very common test. Echocardiogram is an ultrasound of the heart, and so on and so forth. So the top testing procedures really reflect the symptom patterns that we've seen. Patients are short of breath, they're fatigued, they might have palpitations or cardiac symptoms, they may have joint aches, and the testing that goes toward their care really reflects those presenting symptoms. When we first put the clinic together, to be quite honest, and this reflects how the NIH study was designed as well, I think we really thought we were going to have these unique and possibly unrelated clusters. I put 5 clusters here as an example, but who knows how many real clusters could exist. But the reality is that these patients actually overlap more than they are distinct from one another. I think the most distinct clinical phenotypes we see are represented in the slide here, and I'm just going to walk you very briefly to it. We definitely have patients who have very specific symptoms. I have patients that the only problem they have is an unusual tachycardia. It comes on without any kind of physiologic stimulus. I've had patients who've had persistent hypertension for 3 to 4 months post-COVID, and then magically the hypertension just goes away. It's a really unusual phenomenon that I've actually not seen in any other clinical syndrome before, but I've seen it well over a dozen times in the last year. Some patients have pericardial disease and cardiomyopathy. I'm not going to go through all of these examples, but simply put, there are patients who present with very organ-specific symptoms. And then there are patients who have more general symptoms. And those general symptoms tend to be more related to anxiety. Some have a pattern that is very similar to PTSD. In our discussions with the other post-COVID clinics within the UC system, this is also something that is seen at the other UCs. Very much a pattern that resembles PTSD. Many patients have fatigue and confusion and depression. But what I want to emphasize is even in these patients that have very distinct organ-specific symptoms, they often have something else within this general category as well. And so there isn't such a distinct division between these clusters of patients as much as there is overlap in their symptoms. The other thing that we've seen is that hospitalized patients have a more predictable and familiar phenotype. So if we're looking at a patient who survived being intubated, those patients, we're comfortable with what they're presenting with. That is that they often have long-term parenchymal lung disease that frankly does seem to get better over time, but their symptom presentation and their disease-specific presentation is very predictable. Those who weren't hospitalized tend to have a little bit more of a nebulous presentation. The other pattern that we've seen, and this has been seen at some of the other UC post-COVID clinics as well, is there is a pattern of exacerbation of a pre-existing condition. That can include patients who had very mild asthma prior to COVID, and now they have moderate asthma that seems to be more persistent. That could be patients, as one that I saw 2 weeks ago, a young man who had a little bit of trouble with anxiety prior to COVID, but after COVID has panic attacks almost every month and is struggling with that process. So he had a pre-existing condition, and it appears that the COVID infection has exacerbated that. We've definitely seen that pattern. I want to highlight a little bit the role of pulmonary rehab. We are really, really fortunate that our pulmonary rehab facility is in the same facility as our clinic. We have an incredibly dedicated staff who is very interested, not in just these patients, but in all patients. But they've taken the lead at looking at novel ways of dealing with some of these patients' symptoms. We are fortunate that insurance companies now recognize the post-COVID syndrome diagnosis as a reason to be referred for pulmonary rehab. And although many patients who are referred don't necessarily want to go through pulmonary rehab, we have had a few that have. I'm presenting a little bit of some preliminary data in the very initial cohort of 15 that we evaluated that were referred for rehab. So these were patients who had persistent shortness of breath and had fatigue that was out of proportion to their baseline. They were referred to pulmonary rehab, and they went through a 7-week process of pulmonary rehab training, which is usually a 2-time-a-week session. Most of them that participated did report a symptom benefit. We have an almost statistically significant improvement in the St. George respiratory score in these patients, 0.06. I'm not showing that data right now. And they did have a statistically significant improvement in 6-minute walk. And I'm showing some of that data here. Again, this is just the preliminary initial cohort of 15. We're not clear at this point if there's a true objective improvement in exercise efficiency. And what I mean by that is I don't have data to share with you today that the actual VO2 max is improved with pulmonary rehab training. We are, however, hoping to use some of this preliminary data to explore this as a clinical trial for patients who have persistent fatigue and exercise-related symptoms. After a year, what can we reflect on? There are significant challenges in taking care of these patients. I can't emphasize enough, I appreciate the kind words in my introduction that I took the lead in organizing this clinic, but the reality is this has been a huge team effort. And the clinicians and the clinics that have devoted themselves to taking care of these patients, to providing access, we're really doing that work in addition to everything else we were doing. There is no protected time for post-COVID work. All of the clinicians and the clinics that were listed are really doing this in addition to all the other work that we already do. These patients are incredibly clinically complex. It is not unusual that the very first time you see these patients, you spend an hour and a half going through all of the things that are bothering them still. And it is labor intensive to take in all of the different things that are going on. We've had some challenges in the very beginning. It was hard to standardize the intake. We think in these last few months, we've gotten better at this, mostly because our referral patterns are such that the patient can start off in a centralized location, and we have a very standard intake form that we now use to be able to capture some of the discrete data that comes with these patients. These patients come from multiple entry points into the health system. And so trying to get them referred correctly and to start off with the right steps so that intake is consistent has been a little bit of a challenge. The changing definition is definitely going to be a challenge for us as we develop cohorts. The original definition was 1 month when we started a year ago. Now it's 3 months. There are multiple practitioners that see these patients, and to try and have multiple clinicians take a sort of a best practice standard approach to these patients does present some challenges, although I'll say the clinicians have been really great. And there are some patients that we only see virtually. They live far away. We have several patients in Southern California who have reached out to us, and so we've interacted with them by video, and it's much more difficult to obtain some of the discrete information when you're going through that kind of an intake process. We've tried to standardize the workup, the order sets that are used within our electronic health record. We're trying to standardize, but not all clinicians use those same approaches. So sometimes patients get a varied diagnostic approach for a very similar set of symptoms. I think our biggest hurdle so far is data capture. Most of the data mining that I presented here today is done manually. We are in the process of working with our data core and Dr. Jason Adams to standardize our registry and database of these patients, in particular so that it matches what the other UC post-COVID clinics are doing, so that hopefully we all have very similar data definitions. Certainly the challenge of patients sometimes being seen in an outside healthcare system makes it more difficult to pull data out of their encounters. In terms of the future, we really want to focus in the next year on improved recruitment of our underserved and at-risk population. I just don't believe that the most common patient with post-COVID syndrome is a Caucasian patient. Not when such a large percentage of our really sick patients are not Caucasian in the hospital. So I think we need to leverage our telehealth tools to reach out to those who don't have similar access to be seen, whether that's because of distance from our clinics or transportation. But these are things that we are exploring to improve our access. We are actively exploring partnerships with FQHC clinics to provide access for patients who are seen at an FQHC so that they can be seen in the post-COVID clinic as well. And similarly, we are in the process of getting a Sac County partnership off the ground. I already mentioned some of the work with the database and registry and all of the standardization that comes with that. We're very interested in expanding our biorepository. Extremely lucky that our pathology department from the very beginning of the pandemic was able to tag patients who had a COVID diagnosis with all of the clinical data, the clinical specimens that are collected. So what I mean by that, if I'm seen in a clinic and I have a COVID diagnosis, that complete blood count or comprehensive metabolic panel, that can be tagged. And at a later time, if one has an interest in looking at that specimen for a research possibility, through the appropriate channels in IRB, you can get access to those materials. But we hope to expand this biorepository into something a little bit more robust. We are in active discussions in terms of collaborations with our integrative medicine team. I think there are some wonderful non-traditional approaches that can help with patients who have persistent fatigue, concentration, energy, and even shortness of breath. And we're in the beginning discussions of designing an IRB approved clinical trial for those patients. We also have been, as mentioned before, part of multidisciplinary research proposals. I'm contacted frequently by pharmaceutical companies to do clinical trials of therapeutics. So far, I've not been very impressed with what's been asked of us, and we have not engaged formally with some of the products that are that they're trying to test out, but we are always open and willing to listen. And finally, I just want to thank the people who really make this work. It's really not me. It's a much larger group of dedicated clinicians and clinician teams. And I thank all of those teams and strategic partners. In particular, the Respiratory J Street Pulmonary Clinic staff has been phenomenal in this taking on this work. In addition to the work that we already do, this is above and beyond, and of course our pulmonary rehab group. So I can't thank all of them enough. And I'm happy to take some questions. I see that there's a ton of questions in the chat. I wonder if Angela can talk me through it.
Yes, absolutely. Thank you, Mark, for this wonderful talk. It was really a treat for us and very unique. We are privileged because I don't really think there are many studies out there that comprehensively looked at this disease. So I try to tackle the questions if that's okay with the audience, but also if we have time, we could also verbally ask some of them. So the first question was actually from Meg Spalling, and she's asking about the female predominance that you see in your clinic, and she was just wondering if that's because women are more readily reporting or complaining about their symptoms than men, and especially if these symptoms are not particularly specific. What is your opinion on that, Mark?
Great question. I probably wouldn't use the term complaining. I think it is true that women in general, if we're going to make a generalization, are more comfortable talking about some of their healthcare issues than a man is, particularly long-term symptoms. I think there's a component to that. I also think there's an access question. Women tend to see a healthcare provider more frequently than a man does, and therefore there's an access to healthcare that is already set in stone. I think that's part of it. Now, is there something there? Is there a hormonal predisposition for certain symptom presentations, whether it's an autoimmune process or something that's related to a chronic inflammatory state? I think that deserves some investigation. As most of the people on the call here know, that autoimmune diseases also have a female predisposition. And so I do think that there's definitely some opportunity for research.
Yes, David Coyle wanted to know if you have information on the proportion of the patients who are unvaccinated versus vaccinated.
So, many of the patients that we saw initially were unvaccinated because there was no vaccine. The entire year of 2020, there was no vaccine. So all those patients who had their diagnoses at that time and during the winter time were mostly unvaccinated. Now, we see a wide range of patients who had their infection, they were not vaccinated, then they got vaccinated, and they feel that their symptoms got worse. We have some patients who were vaccinated, then got infected. In fact, I saw recently a patient a week ago. She was fully vaccinated, but probably waning vaccination status by the summertime. She got COVID, had severe weakness, and then had her booster, and the weakness got worse. And so the relationship between vaccinated and unvaccinated is still a little murky, mostly because so many of those early patients, everybody was unvaccinated.
Yes. So there are other questions related to the same, asking if you see any trajectory in regards to severity between vaccinated and unvaccinated. So I think you just answered that it's still totally open for research, and it would be interesting to find out. And also some of the vaccines have side effects that could induce some auto-inflammatory symptoms, and that could be mixed with these mixed inflammatory symptoms that come with long COVID. Kent Lloyd and some others are asking nature versus nurture in regards to, is it known whether any environmental exposures might play a role, or there are genetic predispositions that are known for long COVID severity?
I think it's too early to identify a specific genotype predisposition for these symptoms or a particular cohort of symptoms. It's way too early in the game. And similarly, actually, for the unvaccinated versus vaccinated, this most recent wave of COVID infections that really started here in California over the summer, peaked in the late August and now September. It's that group of patients that'll then help us look at that question of unvaccinated versus vaccinated, because that is the richest group that had the opportunity to be vaccinated, and whether they did or didn't, what is the prevalence or possibility for post-COVID. But I think at this point, much of the work that needs to be done going forward is really cluster and cohort discovery within this group of patients. I think there is a difference in a patient that's presenting with principally a tachycardia syndrome versus the patient who's presenting with, let's say, something completely unrelated to the heart. I think there's probably a difference between those patients. Maybe there isn't, but we need to really define the cohorts based on symptoms first, and then be able to look at genetic predispositions as a result.
Yes, and maybe more easily could be tackled. There are many questions in regards to biomarkers, and especially I saw some question about the D-dimer levels. You did mention briefly, I think, C-reactive protein, but are there any other specific biomarkers that you can think of that might be specific or characteristic of the symptoms of post-colitis?
This is one of the challenges of this work, is because these patients are being seen clinically. We can't really put them through a very comprehensive metabolic analysis because their insurances won't pay for it. And then they're going to be stuck with an incredibly large bill. So we use tests that traditionally are used in these types of symptoms. So C-reactive protein, if the patient has symptoms of joint aches or myalgia, then there are appropriate autoantibodies that we would evaluate. But if one wanted to take a deeper dive into the metabolomics of these patients, that really has to be done on the back end using a biorepository through a research mechanism to understand better.
Yes, and I think Sarah Mesbauer asked a question about the geographical tongue, but related to that, to your knowledge, are there any other very specific symptoms that would be that could be used to identify this disease? And the last question from Paulina also, she is wondering about the immune presentations, the rheumatological aspects of the disease as well.
It's interesting. I think if you took us back a year ago, and the reason so many of us got together and said, hey, let's centralize a clinic, is because intuitively we thought we would identify, actually somewhat easily, that there is an inflammatory process that's driving this. And now a year later, I will tell you that the frequency that I see in a patient who, particularly with the new definition, is 3 months out from their infection, that they have any sign that I can identify of an inflammatory process is actually really rare. We don't see a lot of patients with high C-reactive proteins. We don't see a lot of patients with persistent high D-dimers. We don't see a lot of patients with autoantibodies. And it's a little bit opposite to what I thought we were going to see.
That's very interesting. So there are also questions I think Kent Lloyd wanted to know. So how do you treat the disease? Are there any drugs that would be suitable for the symptoms?
Yeah, I think it depends what the symptoms are. So when patients have a distinct organ-specific presentation, I'll use the post-viral cough, then there are certain things that we have used traditionally in that presentation, and we continue to do so. If they've had a very specific presentation, such as venous thromboembolism, obviously we treat that process. But in terms of the fatigue, the difficulty in concentration, the difficulty in energy, being able to repeatedly do work that previously was easy for them, and now you go for a hike and for the next 4 days you feel like you can't do anything. Those patients, we do not have a specific treatment. I've been approached to do plasmapheresis on these patients, but since I can't identify an actual hyperproteinemia or an inflammatory protein that's elevated, I didn't really think that that was an appropriate way to try and treat these patients. We are exploring, as I mentioned, some more non-traditional approaches. I do think, to be honest, that exercise probably makes a difference, but we want to formally test that out. And in general, now having the benefit of a retrospectroscope, these patients over time get better. I would say about 60 to 80% of our patients, eventually things come back to either normal or near normal. But it's just for some, it takes a long time.
Yes, I also had a question related to exactly this, because this reminds me of the symptoms of POTS, the postural orthostatic tachycardia, with the brain fog, the depression, the nausea, the anxiety, and the tachycardia and the exercise intolerance, for which it was shown that beta blockers and exercise are the two main treatment that actually works. So I don't know if you feel the same way, but I'm really glad you mentioned that even though there is exercise intolerance in these patients, you still feel that exercise is the best way to approach it. And I have some questions from Laura, Chris, but also David Coyle were wondering about asymptomatic COVID-19 patients, and how do you verify that these people have actually been infected with the SARS-CoV-2 virus, and are you planning to include at any point patients who never received positive diagnosis?
So that's I'll make the answer very, very brief. We are not seeing anybody who doesn't have evidence that they actually had COVID. And the reason is not because we're in some ways being judgmental. It's an issue of access. It's hard enough to find clinical time and space to see all of these patients. If we now open the door to all those who felt like they had it, but because of the timing of the situation, just were not able to be diagnosed, that door would be so wide open that it would essentially overwhelm our clinic. And so for that reason, we have kept it strict. There are obvious exceptions. And so we do have a handful of patients that I don't have an actual diagnosis, such as a PCR or an antibody test prior to a vaccination. But it appears likely that they had COVID, mostly because their hospitalization very much matched what we might have in a patient with COVID. But unfortunately, it was earlier than all the detection systems were available. And so it's very limited, but for the most part, we just don't have the space. We don't have the access to see that additional cohort of patients.
Yes, thank you so very much. We are out of time, and I have to let you go because you are seeing some patients. So thank you so much, Mark. It was wonderful. And if you guys have any additional questions, feel free to email me, and we can forward it to Mark as well. So thank you again.
Yeah, absolutely. If there are additional questions that we didn't get to, maybe we can put them all into sort of one email, and I'll try and knock them off. Okay.
We'll do that. Thank you
all
very
have
much.
a wonderful weekend.
You too. Thank you.
Bye-bye.
Bye.